use of your time. As you know, experts say that oftentimes our zip code is more predictive of our health outcomes than our genetic code. And so today what we're going to do is examine ways that we can address the social determinants of health and improve the health outcomes of individuals and communities from leaders who've devoted their work to forging a healthier future. Rather, would you share a little bit more about sort of what you're seeing hospitals and health systems do to address the cultural competency and the readiness of the workforce?
And if we're going to be successful and move the dial, it's going to take collaboration and working together. So having those guiding principles in mind, we formed sort of a coalition made up of hospitals, area schools, some nursing homes to really look at this issue and say, we have 30 hospitals that are in 14 counties, which range dramatically in demographic makeup. So on a regional level, we realized that each of the areas are going to have variety in their recruitment patterns. But if we worked regionally, could that look like? So we identified 4 key impact areas that needed to be addressed on a regional level to move the dial on our workforce diversity, because we realized that we have work to do in healthcare. So one of them is raising awareness around the careers with the right group of folks. So that looks like building an online platform to connect mentors with students from K through 12, because we've identified that as being a key group for students. If they believe they can be doctors and nurses, they will go into those careers. And so we have a great mentorship program going on with healthcare professionals, docs, nurses that work currently that can sort of support those students.
What are some of the best practices or innovative solutions that you're seeing as it relates to sort of what systems are doing today with their existing staff to ready them for the increases in diversity in the patient mix?
I think what we're starting to see at Rush University Medical Center is a focus from the highest level of leadership to the staff and faculty to really focus on this idea. In our mission, we have focus for 2025 on being a diverse and inclusive group of providers, and that requires more than just a diversity of who we represent and who's there on the team, but that every team member is inclusive of other team members so everybody can share in that experience. That has led to a large amount of celebration and programming around celebrating the diversity we have in our community. In the center that I belong in as a geriatrician at the Rush Alzheimer's Disease Center, out of a staff of about 100 individuals and 10 faculty members, we represent 50 countries.
So I came from academic medicine and thought about diversity as in pipeline and developing the workforce, very similar to what Dora and Raj have just said. Something that I hadn't thought about as much until I started my current role in the health department is what it really means to recruit from the communities that we serve. And specifically, let me give you an example of best practices. One of our programs that we're very proud of is something called Safe Streets. It's based on the Cure Violence model that started in Chicago, and basically, we believe that violence is a public health issue. I mean, I'm an ER doctor, I see the end results of violence, and so I know it's a public health issue, but we also believe that violence is something that you can prevent, that you can interrupt, and you can treat. And so we hire individuals, most of whom are ex-offenders, recently returned citizens, to walk the streets of Baltimore. They come from those communities, and so they're credible leaders. Many of them used to be gang members, gang leaders, drug dealers, and now they are interrupting crime when they see it. Last year, even though our interrupters only cover 1.5 square miles total in Baltimore City, they mediated 880 conflicts. 80% of those conflicts were deemed to be likely or very likely to result in gun violence. One of our other signature programs is Be More for Healthy Babies, which has resulted in record reduction in infant mortality rate. And we hire community health workers to talk about safe sleep, the ABCs of safe sleep, moms who've used these methods themselves. Much more credible, again, than my talking about it myself as a healthcare worker.
Would you share a bit about the Health Collaborative and particularly through the lens of the work that you're doing relative to collecting, analyzing, and leveraging patient demographic data to look at health outcomes in your region?
Correct. About 3 years ago, we went through a process to standardize the data collection of race, ethnicity, and language of the patients of our 30 hospitals. We realized that, one, we really weren't clear on what the disparities were because we didn't have the data that was consistently gathered across the community. And when you don't know what you don't know, you can't improve it. So that was a process we went through and did a baseline survey and gathered sort of the current state of the arts that folks really didn't know what that looked like. So we standardized using some evidence-based standards, OMB. And we really used some national data to prove the points. Basically, what's the evidence of need? We had 40% of our African American patients were more likely to die from complications of diabetes and heart failure than other races, which is a huge disparity there. So we went through a series of training to gather that data, to train registration staff on how to safely ask for that information, so you're sort of eyeballing the patient. So we had really good source of database. And we really created a culture where it was safe to share this information. We kept the information confidential, and it was only to be shared by the participants, and really were able to learn through that environment. We also created some accountability from the top. We had board level champions, CEO champions that were sort of rooting the teams on that this was important work. We've seen since then a 20% reduction in improvement for African Americans that are dying of diabetes in our region. So we're really trying to do more targeted work with the Hispanic population and African Americans. We've created sort of a regional scorecard that has picked some 5 key indicators so we can keep track of that on a regional basis.
We know that Chicago is a diverse, but it's a segregated city, both socioeconomically and racially, which leads to a disproportionate burden of poor health among certain communities, right? So with that in mind, can you share a bit about Healthy Chicago 2.0, and in particular, explore the hardship index for us?
So to have a 16-year life expectancy difference by 2 communities, maybe about 10 miles, 20 miles apart, is quite remarkable. And what it tells us, and where the Public Health Department has gone with its Healthy Chicago 2.0 sort of community health needs assessment, is the fact that we need to not only improve the key factors of letting people live longer, letting people live without suffering, but to make sure everybody has an equal chance of obtaining number 1 and number 2. And hospital systems in general have to take a broader view about really impacting their communities around equity, not only by who they are internally, but then how they work in the ecosystem that makes a difference in their communities. Well, one of the most amazing things that came out was that there was this publication of a map of Chicago with something called the hardship index. The hardship index is based on factors that we don't always think about in healthcare, but things like unemployment rates or a combination of graduation rates from high school or housing stock in a neighborhood. And they put that together in this variable of sort of 6 measures of sort of community well-being and put it on a map. And they show the communities in Chicago that were in the worst quartile compared to the ones in the better. And where we're based on the west side of the city, we have some of the communities most affected by hardship right next to us. And then we had to start working with other partners we never thought we would work with to fundamentally change this. We had to work with individuals that were in the communities as community-based organizations that were seeing things on the front lines every day and getting focus groups and listening to their voice. We had to work with our public health departments in a different realm to really make sure we had a difference. And the final thing we had to work on is to get better coordination of data and data systems. And some of that work was funded by a program with PCORI, the Patient-Centered Outcomes Research Institute, called Capricorn.
Stephen Lewis, our keynote earlier, did such an exemplary job of explaining why health is not just about hospitals, which is something coming from the hospital world. It took me some time to understand this, right? I always thought if I became the best doctor that I could be and delivered excellent acute care, then that's what we need to do to save people's lives. But I think he made a great point, and Raj just then added some excellent points too about how our zip codes determine much more than our genetic codes about what ends up happening. And also we have to think about health in a much broader context, that we have to think about how health and poverty are so closely interrelated, and how if we don't have the right food, if I tell my patient, well, you need to prevent heart disease by exercising and by eating good food, but 1 in 3 African Americans in Baltimore City lives in a food desert without access to fresh fruits and vegetables. And we have plenty of middle schools, elementary schools, and high schools where students don't have recess because it's unsafe. They don't have recess. How am I supposed to be telling them to exercise? What is it that we're doing so that we are building for better health? So we have worked to convene all of our hospitals, insurers, FQHCs, foundations, nonprofits, similar, I think, to what's being done in Chicago, so that we are trying to align towards at least two of the same goals, which are youth health and wellness and around behavioral health, specifically mental health and addiction services.
So Lena, earlier this year, we watched, as did the rest of the world, when Baltimore ignited in protests after the arrest and the subsequent death of Freddie Gray, a 25-year-old African-American resident of Baltimore, right? So would you share your insights and experience during that unrest?
Lessons that I learned. One lesson is that this is our chance to try to break the cycle. And what I mean by that is it's easy for us to see the problem as here are the perpetrators of violence. Right? We see hundreds of teens and youth doing crazy things, and we say, well, that's the problem. They're perpetrators and there's something wrong with them. But looking one step deeper, and we see that each person is the victim of significant trauma. Right? Trauma is grief that's unexpressed, presenting as anger. And we see such unmet mental health needs in our city. So what we're doing is, for example, we are making our city trauma informed. We're beginning to train every frontline city worker, policemen, police officers, school teachers, social workers, everyone, on how to recognize and treat the effects of trauma. Another lesson that we learned, and I think this goes back to, I just loved our keynote, is the idea of going to where people are. Right, and to engaging our communities in the way that they need, rather than us saying, here are the things that we need you to do. And so, we have had the struggle, and I think many of you, your communities have the struggle too. People will say to us in the health department, why do you still provide direct clinical services? Because we run 2 health clinics, and we also serve the health needs of 189 schools. We have health suites in every single one of our schools in the city, which is a lot of direct clinical service. I mean, most of my over 1,000 employees work in direct service in some way. And I'll say, well, that's great if every child has a primary care doctor. If we live in Bethesda, if we live in, I don't know what are some nice areas here, but if we live in an area where every child does have a pediatrician, that's great. But we have thousands of our children who are homeless. We have half of our children who live beneath the poverty line. We have a situation where we can't deliver clinicals. We can't expect people to come to us for their clinical care.
I would say, I think it's been talked about today, is really thinking about relationships in a very different way, branching into non-traditional partnerships. We're seeing hospitals reach into churches, African American churches, Latino churches, forming partnerships with YMCAs. It's really going to take that to make a change and go into the neighborhoods. We have countless community-based organizations that are the boots on the ground that go into the neighborhoods, understand the culture, understand the population in those areas. And so those are the kinds of partnerships that we're seeing really make a difference, because we're not able to do that from our hospitals and clinics.
So there are powerful levers that we all have in our organizations that might not be just delivering on healthcare, but slowly you can transform that healthcare into other things like education or workforce development that can help people to improve as a community, and then live healthier lives, have more resources, and then share that and build their communities to be a better place.
So if you could create a community-based organizing framework whose mission is to create the optimal health and well-being of the community, what would that look like, and who would be the drivers of that work?
Can I talk about what that would not look like?
Nice.
Right after the unrest, and I'll just give you an example because it blew my mind at the time, right? So after the unrest, we set up our prescription access line. We had set up a mental health access 24/7 line as well, because people were going through so much trauma and other issues that we wanted to get the information out, because we couldn't expect that they were looking at our Twitter account or they were watching news. But we needed to get that information out to our community. And so we went door to door in senior buildings, in churches, on the streets to get information about our lives. We got 2 questions. First question was, this was 2 days after the unrest. First question was, what candidate is this for? Right? People really thought that right after the unrest that we were already putting things out for the next city council or whatever. Second question, what survey is this? Because I think I filled out a survey last week. people in our community were not trying to be snarky, they weren't trying to give us attitude, but actually they were expressing that they think we're always here for our purposes and not for theirs. And I don't put blame on anyone, right? I've been in academia, I understand the reason for us, we have grants, we have things that we need to fulfill, we have to do work, and we really believe that we're doing the right work. But what ends up happening is that our community feel like we're there for their gain, and not or for our gain and not for theirs. So one of the strategies that we've set up in the health department is we have said, look, we know that some of the work that we have to do, some of the goals that we have to set, do have to come from top down. Because if you ask our community what's the most important thing to you right now, they're probably not going to say life expectancy, smoking cessation, reducing obesity. I mean, they're probably not going to say that. But if we just say, here's what we have to do in public health, we're going to lose their attention span. And they're going to say, again, this is your goal, this is your plan, this is not mine. So what we've done is to say, we are going to set our long-term goals, but we will ask our community to set short-term metrics.